Welcome back to the next section of neonatal resuscitation. What we're going to go over now is the care for a non-vigorous or a preterm infant. What we just went over is a baby that does well and can go directly to mom. But what about the infant who can't? So if any of the answers to the questions in the pink triangle, is the baby term, is the baby tone, is the baby breathing or crying, or no, then the baby needs to be brought to the radiant warmer to determine if additional interventions will be required. First thing that we do when we get to the warmer is check the baby's temperature. Our goal temperature is between 36.5 and 37.5. The baby should be placed on the radiant warmer so the resuscitation team has easy access to the baby without causing excessive heat loss. We need to leave the baby uncovered to allow visualization and to permit the radiant heat to reach the baby. If you anticipate that the baby will remain under the warmer for more than a few minutes, we need to go ahead and apply one of the servo-controlled temperature sensors that we have for the baby. It connects directly to the baby's skin, and with our giraffe, what it does is it automatically acclimates the temperature of the warmer to the baby's temperature to reach our in temperature goal. This is to avoid both hypothermia and overheating the baby. During resuscitation and stabilization, the baby's body temperature should be maintained. Next, we're going to place the baby's head and neck in a position to open the airway. The baby should be positioned on his or her back in a supine position with the head and the neck neutral or slightly extended. This is what we call the sniffing position. This position opens the airway and allows unrestricted air entry. Avoid hyperextension or flexion because both of these positions may interfere with air entry. To help maintain the position, you may place a small towel under the baby's shoulders. This often ensures that the baby stays in the correct position, especially considering the large occiput or the back of the head of the baby. It helps protect that area as well. So we need to go ahead and remove secretions from the airway if needed. We need to clear the secretions from the airway if the baby is not breathing or is gasping, has poor tone, if secretions are obviously obstructing the airway, if the baby is having a difficult time clearing their own secretions, if they're meconium stained fluid, or if you anticipate that you're going to have to start positive pressure ventilation. Secretions may be removed from the upper airway by suctioning gently with a bulb syringe. If the newborn has copious amount of secretions coming from the mouth, turn the head to the side in order to ensure that the baby does not aspirate those secretions. That way the secretions can collect in the cheek and can be removed more readily. Brief gentle suctioning is usually adequate enough to remove secretions. Suctioning from the mouth before the nose is important to ensure that there is nothing for the newborn to aspirate if he should gasp when the nose is suctioned. So M before N, mouth before nose. Be careful not to suction too vigorously or deeply. Vigorous suctioning can injure the tissues and stimulate the posterior pharynx during the first minutes after birth and can produce a vagal response leading to bradycardia or possibly even apnea. So if you're using a suction catheter, we need to go ahead and set the suction to a negative pressure that reads approximately 80 to 100 millimeters of mercury when the tubing is occluded. Then we're going to dry the baby, discarding the wet towels or blankets that we're going to use. Wet skin increases evaporative heat loss. We place the baby on a warm towel or blanket and gently dry any fluids. If the first towel becomes wet or subsequent towels become wet, go ahead and discard them, and always maintain the use of fresh warm towels. Drying is not necessary for a very preterm baby, less than 32 weeks gestation, because they should be covered immediately in that plastic bag or that polyethylene plastic wrap. This intervention is used to reduce heat loss in very preterm babies. We want to go ahead and stimulate the baby, gently rubbing the baby's back and trunk and extremities. Never overly vigorously stimulate the baby. It's not helpful, and if stimulating does not work, we need to move on to the next assessment and action.
Dry them off.
The initial steps are then completed with drying, stimulation, and removal of wet linen, followed by repositioning of the airway. Evaluation of respirations, heart rate, and color follows, with administration of free flow oxygen if necessary for central cyanosis.
Heart rate's good, it's over 100. Just trying to make some good respiratory effort. That's 1 minute.
Stimulate them a little bit.
Okay.
It's pinking up very
Yeah,
nicely.
it's definitely picking up.
Good cry.
This baby is still at risk for developing problems and requires observational care while with his mother.
See how he does without the oxygen? Looks good. He's a cute one. You wrap him up, giving him on?
So let's review what we do in the initial assessment of the baby. We go ahead and reposition the head and the neck to open the airway. We may use a suction device, either a bulb syringe or a suction setup, and we set that between 80 and 100 millimeters of mercury. We can place an SpO2 monitor on the baby. If we do this, we want to place it on the right hand or the wrist. We administer supplemental oxygen via blow-by. Never administer supplemental oxygen by a self-inflating bag. I'll go over the bags with you as well. Free flow is administered at 10 liters per minute at a blend of 30% oxygen. Remember, we do not want to deliver 100% oxygen to these babies. Remember that the newborns transition from 60%, which is normal in uterine state, to 90% is a more gradual or eventual state. So we always need to be mindful of the preductal SpO2 target levels. So the target goal or the referred goal is 90% at 9 minutes. The neonatal bag and mask devices that are most often used are the self-inflating bag. That's the one that we have readily available on our giraffe. There's also a flow inflating bag, and you are going to learn how to use this device. This is available to us in the neonatal carts in the emergency department. And another device used is what they call a T-piece device, which we will not be using. So in the previous example, in the previous video, obviously one of the answers to this initial assessment up here was that the baby was either not term, not tone, or not breathing or crying. So when they went through the temperature, they repositioned the airway, they suctioned the secretions as needed, they dried the baby, and they stimulated the baby was able to go back to mom at that point. But what if all of that from the previous video did not stabilize the baby? Then we need to go down into assessing whether or not the baby is apneic or gasping, or the heart rate is less than 100. We will discuss if the baby has persistent cyanosis or labor breathing later in another section of the class. So what are we going to do now? We've done all of these things and the baby is not responding. So what do we do if the baby is gasping, apneic, or the heart rate is less than 100? What we're going to do is we're going to start positive pressure ventilation. We're going to apply the SpO2 monitor if it hasn't already been applied, and we may consider at this point go ahead and putting leads on so that we can get a more accurate picture of the heart rate response. Remember, ventilations of the baby's lung is the most important and effective action during neonatal resuscitation, and a rising in the heart rate will be indicative that the positive pressure ventilation is successful. So we're going to prepare for positive pressure ventilation. We're going to clear the secretions from the airway. We're going to position ourselves at the baby's head. We're going to position the baby's head and neck in that sniffing position. We're going to select the appropriate mask with the correct size. And we're going to place the mask on the baby's face using the one-handed technique or the two-handed technique with the jaw thrust. Now for the oxygen concentrations that we're going to use. For greater than 35 weeks gestation, we're going to set the blender at 21%. The blender is currently set up on the pole on the giraffe, and we will review its function during class. If the baby is less than 35 weeks gestation, we're going to set the blender somewhere between 21 and 30%. Remember, we do not start off by giving these babies 100% oxygen. The flow meter will be set at 10 liters per minute, and we will use the target preductal SpO2 chart for the saturation comparisons. We need to make sure that the giraffe's timer was set at the time of delivery so that we can ensure that we are meeting our target SpO2 levels. The breath should be given at a rate of 40 to 60 breaths per minute. When you are demonstrating this, it kind of sounds like a tango. Breathe 2, 3, breathe 2, 3, breathe 2, 3. We're also going to start the peak inspiratory pressure at 20 to 25 centimeters of water. Remember what I said about the heart rate. The most important indicator of successful PPV is a rise in the heart rate. And we're going to check the baby's heart rate after 15 seconds of PPV. But before we do this, I want to review the administration of positive pressure ventilation. First, let me go over a few things specific to our emergency department and the equipment that we have available to us. I want to review the temperature probes. We have them in heart shaped. This one is in a little bear shape. We have the probe, and the probe connects directly to the backside of the giraffe. I want to pay close attention to the screen on the giraffe. Once we do apply the temperature probe to the baby, then we want to put the giraffe monitor on baby. As you can see, it is alarming because it's not on a real baby and it's saying that the temperature is way too low. But this is how, press this button, you switch back and forth from manual to baby, and when we have a resuscitation or a delivery in our emergency room, we want to put the temperature probe on the baby with the temperature probe line going into the giraffe, and make sure that we allow the monitor to do the work for us. Another thing is also, when the baby is born, we want to press this button up here and start the timer. This is very important for our preductal SpO2 level targets, and also we have that golden minute. If the baby's not doing well, we need respirations or positive pressure ventilation started as soon as possible. Also on the giraffe, what I want to review is, I told you guys that I put the oxygen blender directly on the giraffe. It is already set up in line in the wall, connected to both medical air and oxygen. This is where we will use our blender. You can see the lowest rate is set at 21%. That will be just infusing medical air, and that's consistent with room air. But if we want to give blow-by, we can set it up in order to meet our preductal SpO2 target levels. And of course, if the baby's doing terrible later on down in the algorithm, we can certainly push it up to 100%, but that's only down in the algorithm because of the potential for hypoxemia and the toxic effects of too much oxygen. We receive the baby post-delivery. We want to get the baby on the warmer. We're going to start drying the baby. Once that blanket is wet, we want to go ahead and discard it. Continue to dry the baby. I'm going to go ahead and position the airway. I'm going to go ahead and suction the baby. I want to go ahead and suction from the mouth first and then from the nose. I want to make sure I suction from the mouth first because when I suction from the nose, the baby may gasp, okay? And when the baby gasps, anything that's in the mouth would go directly into the lungs. So make sure M before N, you suction from the mouth and then the nose. All right, I got the secretions out of the way. I have the baby under the radiant warmer. I do not want to monitor the temperature manually. I want the machine, for safety and best practices, to gauge the temperature according to the baby's body temperature. So once I place it on, I put it on baby mode. And of course the timer has already been set at the time of delivery. So I'm gonna go ahead and I'm gonna try to stimulate the baby, The baby is apneic, the baby is limp. So what I wanna do is I wanna administer positive pressure ventilations. These are the bags that we use in our emergency department. You will see they're more like the surgical ambu bags. We want to go ahead and place a tight seal on the baby. When we're positioning the head, we want it to be in the sniffing position, not underextended, not hyperextended, because of the anatomy of the trachea. So we use the EC. I'm going to make the E out of here and the C on the top of my non-dominant hand so that I can have control over my bag. So my oxygen is set at 21% blended. And if you can see here, our manometer is on our flow inflating bag. You can see the manometer on the top, and the green section is, when the green section stops, that is 20 centimeters of water pressure. We're going to initiate positive pressure ventilation. 3, 2, 3, breathe, 2, 3, breathe, 2, 3, breathe, 2, 3, breathe, 2, 3. I'm going to initiate this for 15 seconds, and then I'm going to check the pulse again. What you can do to check the pulse if you don't have an ECG connected is to auscultate the left side of the chest. You can do when you're checking the pulse, since you a lot of noise going on, it's a really rapid succession of activities that's going on, you can tap out the pulse that you're getting. You would count it for 6 seconds and multiply it times 10. And remember, the best indicator that your positive pressure ventilation is working is a rise in the heart rate. For this scenario, the baby's heart rate rises to 100%. So we want to continue to monitor the baby's temperature, which is 37 degrees Celsius. So we're in a good range for the baby's temperature. We're going to continue to dry them, monitor the O2 sat. While other team members are preparing for positive pressure ventilation or beginning positive pressure ventilation, we need a team member to set up the SpO2 so that we can determine how well we're doing with our PPV. We always want to put the sensor on the right hand of the baby. And once we do this, our monitor is not set up directly on our giraffe, so we will be using our neon code monitor, which is right next to the giraffe. So now we've set this up and we can begin the positive pressure ventilation.
Okay, let's warm the baby. Suction the oropharynx and nose. Okay, let's take off this wet blanket.
All right.
Baby is not breathing.
The initial steps of resuscitation have been completed, and the infant is still not breathing. Ventilation is the single most important and most effective step in neonatal resuscitation. Heart rate is monitored as positive pressure ventilation begins because a rapid rise in heart rate is the best indicator that inflation pressures are adequate.
I feel like I have a good seal, but I'm not getting good air entry. And I resuction the oropharynx and nose.
If heart rate, color, and muscle tone are not improving, look for chest movement
Reposition the
and listen
airway.
for breath sounds.
No, I think we have everything under control now. The baby's heart rate's coming up.
Okay, thanks.
Thank you. Heart rate is around 120.
Okay, looks like the baby's breathing well. Turning more pink.
Okay.
And we have a good heart rate.
This infant who has received positive pressure ventilation will
Hopefully,
require
take away the
post-resuscitation care with ongoing evaluation and monitoring.
How about we have Dad come over to the warmer while we just make sure the baby's breathing okay?
That sounds good.
After the initial steps, if the baby's still apneic or their heart rate's less than 100, then you start positive pressure ventilation. As soon as you start positive pressure ventilation, ask your assistant to listen to the heart rate for response. If the heart rate's improving, continue what you're doing. If the heart rate's not improving, then you have to start the ventilation corrective steps. That's the Mr. SOPA steps, and they don't take very long. Start with the first steps. Reposition the head and neck, reapply the mask. That's the M and the R in Mr. SOPA. Start ventilating again. Give 5 to 10 breaths and ask your assistant, is the chest moving now? If the answer is no, then you move on to the S and the O. The S and the O is suction the mouth and the nose and open the mouth. Restart ventilation. Give about 5 to 10 more breaths and ask, is the chest moving now? If the chest isn't moving now, then you have to move on to the pressure step. You're going to increase the pressure in increments of 5 to 10 centimeters of water. So you give more pressure and ask your assistant, is the chest moving now? If the answer is no, give more pressure. Once you've reached the maximum pressure, about 40 centimeters of water, then you've decided mask ventilation isn't effective, and you have to move to the last step. That's A, for alternative airway, and either insert a laryngeal mask or intubate.
So let's review what we've gone over so far. It's going to be in this circle, this 1 minute. So we must start the PPV within 1 minute. It's called the golden minute. So let's review what we've done so far. The triangles will be assessments and the rectangles will be actions. When we're in our team briefing and our equipment check before the birth, we must ascertain as much of the following questions as we can. What is the expected gestational age? Is the amniotic fluid clear? How many babies are expected? And are there any risk factors? Once the baby's born, we must ask, is it term? Is it tone? And is the baby breathing or crying? Once we get down to these actions right here, we must ensure that the temperature is 36.5 degrees and 37.5 degrees Celsius. We're going to position the airway. If we need to suction the secretions with a suction setup, we need to use a 10 French or a 12 French. If we do need to administer free flow oxygen, we can do so. We can use the tail of our ambu bags, or we can just use the tube. We can set it to a blend of 30%, and we will set the free flow at 10 liters per minute. If we do drop down into the baby being apneic or is gasping or the heart rate is less than 100, then we need to start with oxygen per PPV. Our oxygen concentrations will be 21% for 35 weeks or greater,
and they will be anywhere from 21 to 30% for under 35 weeks gestation. And again, the flow meter will be set at 10 liters per minute. The breaths we give should be 40 to 6 breaths per minute. It will sound something like breathe 2, 3, breathe 2, 3, breathe 2, 3.
And we will start the peak inspiratory pressure at
20 to 25 centimeters of water. Remember that the most important indicator of successful positive pressure ventilation is a rise in the heart rate, and we will check the baby's heart rate at 15 seconds of PPV and again at 30 seconds PPV, which we will go over shortly. And if we have any issues with the mask, we will use the Mr. SOPA algorithm by first adjusting the mask, then repositioning the airway, then suctioning the mouth and the nose, opening the mouth. The P, we will increase the pressure in 5 to 10 centimeters of water increments to a max of 40 centimeters of water. And if none of this works, we may have to consider an alternative airway. We will do that in the next section. Our first assessment of the heart rate will be after 15 seconds of positive pressure ventilations. If the heart rate is increasing, we need to announce loudly to the team, the heart rate is increasing. We need to continue positive pressure ventilation, and we can assess the heart rate again after another 15 seconds. If it is not increasing, but the chest is moving, we need to announce the heart rate is not increasing and the chest is moving. We need to continue positive pressure ventilations that moves the chest and do another heart rate assessment after 15 seconds of positive pressure ventilation with a moving chest. Now, if it's not increasing at all and the chest is not moving, we need to announce the heart rate is not increasing and the chest is not moving. We need to go through our Mr. SOPA algorithm to see to be sure that we are administering adequate positive pressure ventilation. And if we are, we may need to consider to intubate or use a laryngeal mask if needed. We need to announce to the team also during positive pressure ventilation if the chest is moving and continue the PPV once it does start moving. The second heart rate assessment will be done if the heart rate is not increasing and the chest is not moving after another 30 seconds of positive pressure ventilation if we have begun to move the chest. Our second assessment will be after 30 seconds of PPV. That moves the chest. Again, we will assess if the heart rate is at least 100 beats per minute. If it is, we continue positive pressure ventilation at 40 to 60 breaths per minute until there is spontaneous respiration. If, however, the heart rate has dropped from 60 to 90 beats per minute in our second assessment, we need to reassess our ventilations and use the Mr. SOPA algorithm as necessary. If the heart rate is under 60 beats per minute, again, we reassess the ventilation, we go through our Mr. SOPA algorithm, and we insert an alternative airway. And now in the algorithm, if there is no improvement, we can administer 100% of oxygen and we start chest compressions, which again will be in another section. So that is positive pressure ventilation and the subsequent assessments that are required for this level of the algorithm.